Welcome to Big Ideas in Overdose Prevention. Invest in health equity and build partnerships that work. My name is Jeff Bornstein, and I'll be running this Dialogue for Health web forum with my colleague Merlene Tucker. Thank you to our partner for today's event, the National Overdose Prevention Network. Now it's time to meet the moderator of today's event, Dr. Carmen Rita Nevarez. Dr. Nevarez is the Director, National Overdose Prevention Network, Director, Center for Health Leadership and Practice, Director, Dialogue for Health, Senior Vice President Emeritus, External Relations and Preventative Medicine, Public Health Institute. Carmen, it's great to have you here. Welcome.
Yeah, thank you, Jeff, and welcome to everybody who's joining us today. We're really glad to see the interest in these topics. This is, as we said, part 2 of introducing 5 big ideas in overdose prevention. And what we're going to do today is focus on investing in health equity and building partnerships that work. So today's session is actually formatted a little bit differently than our usual webinars. If you were on the last webinar, you know how this goes. We'll be viewing some clips that were taken from some of the really brilliant minds and people that were part of the National Overdose Prevention Leadership Summit in November of last year, and we'll be pulling them together into a short little film clip. After that film clip, we'll have an opportunity with you, the audience, to go through some of the ideas that were in the clips, hear from you about some ideas about partnerships that work in the first section, and then in the second session, why we invest in health equity and how we do that better. In order to do this and to do this well, we do this as a team process. Myself and Dr. Maddox Gonzalez, who I'll introduce in just a second, will be having conversation and also introducing your ideas back to the audience. So just so that you know, in the coming months, we're going to have a webinar on each of these big ideas and really go into focusing in depth on the topic areas that have been raised. So let me go ahead and introduce my partner, my co-host for today, Dr. Mary Maddox Gonzalez. I'm really pleased to have you, Mary. Mary was with me on the last webinar. She's a physician and public health professional with over 30 years of experience in safety net primary care and public health. She served as the Sonoma County Public Health Officer and also the Division Director and as the Chief Medical Officer of Redwood Community Health Coalition of Community Health Centers in Sonoma, Napa, Yolo, and Marin counties from 2011 to 2016. Since then, she's been working with us at the Center for Health Leadership and Practice as an impact coach, and she's just been a wonderful partner in this work. So welcome, Mary. Good morning. Today, what we're doing is we're going to spend our time looking at 2 issues. We're looking first at partnerships that work, building partnerships that work as a strategy for overdose prevention. And the second is looking at investing in health equity. We are hoping that in the months ahead that we do have this opportunity with you to go deeper into these topics. But for today, let's get an overview of the importance of investing in health equity and the building partnerships that work, why they matter, some real life examples about them, and let's also at the end just get a preview of the future webinars that we have in this area. So let's go ahead with the 5 slides, 5 big ideas in overdose prevention. In case any of you missed the first webinar, what we covered was reaching people where they're at, being willing to pivot, and don't reinvent the wheel. And the whole webinar is available in its entirety, and you'll be able to find the link to that at the end, where we'll show the slide that has that has links that'll take you to that. I highly recommend that you get a chance to look at that. It's a nice distillation of some of the ideas that were presented at the National Overdose Prevention Leadership Summit. And the content is just extremely rich, as I hope you'll find today. So today, go next slide. We're focusing on building partnerships that work and investing in health equity. Next slide, please. So when we talk about building partnerships that work, we know from our experience in California and across the country that collaboration with key partners really does matter. There are people in some parts of your community who have much closer relationships, either with the communities that we're trying to serve or with some solutions that we haven't thought about yet in our own, in the bubble in which we usually work. We want to make sure that we are really thinking as broadly as we can about why and how it's important to bring together that variety of leaders, of stakeholders, to really get a strong response community and inclusion community that we have seen leading to better health outcomes and fewer overdose-related deaths. So all of the people, all of the groups that are represented in the circle here are really a part of that community. Be conscious as you think of walking through your community, who you can bring to the table and how you can make them part of your community. So let's go ahead and roll that first film.
Welcome to our video series on 5 big ideas in overdose prevention. The following clips are from the National Overdose Prevention Leadership Summit and focus on big idea number 2, build partnerships that work.
One of the things that I walked away with was the need for us to feel more urgently that this crisis has to be addressed similar to the way we have the COVID crisis. We have to not only rethink how we are providing services, but we also have to rethink the policies that we have in place that make it difficult for us to provide the innovative approaches that we heard yesterday could be so effective in helping people live healthy, productive lives and also deal with their substance use. And it was a challenge. I think we had a gauntlet thrown down that all of us, no matter where we're working, have an opportunity to change the way we think, fund, and provide services for substance use disorder and to prevent more overdose.
I know personally and intimately that in my own recovery, it was peers before they were called peers. They were peers in recovery who really showed me that not only was recovery possible, but living a successful life, having this great career was also possible. So we need to have this separate role within clinical spaces, within treatment, within community-based spaces, because the addiction counselors and social workers cannot deliver this specific messaging, but it's needed. So if we can help move the field forward, we can help train those clinical spaces, the supervisors, to have a better understanding of the differences in those ethics between being a recovery coach and being an addictions counselor. If we can train all the staff within those clinical settings to understand the value of the role, and then we can train all of the peers to have the same standard of training, then we can, I really believe, make a huge difference in the trajectory of this overdose crisis that we're in right now.
So what we do is we actually have a digital handoff. So EMS patients who are seen for substance-related reasons are digitally referred to the substance use navigator. They refer and provide referrals to MAT and connects patients to other county resources. And how do we do that? We do that digitally. We don't rely on anybody like making a phone call or filling out a page. It's all done electronically. The field medic documents their care as normal. And then we have a secret sauce, which is a company called First Watch, which does data mining of all of our records. And if it fits into our trigger, then the son gets an email on this case. Then the son logs in and is alerted for further follow-ups. So this is a trigger that is the data set can use multiple sources.
I think historically the state attorneys general first kind of came to prominence really with the tobacco master settlement agreements decades ago and all kind of banded together. And there were some concerns about how the billions of dollars of that settlement ended up being used, because while they went back to the states, they sort of went for general use. They went to general funds. And in this particular settlement, the emphasis from the get-go has been, whether it's states or counties and cities, first of all, let's make sure that an adequate amount of funds is deployed to local municipalities because they're nearest and closest to the issues and problems. Certainly we need state programs funded, and there's a synergy having state and local funded together. So that's a critical component, and without getting into all of the specifics of percentages and everything else. Also, that the money would be focused primarily on avoiding another generation of addiction. So prevention, awareness, and then also to address treatment and recovery for those who are currently trapped in that cycle. I want to say this, one thing it doesn't address, and people ask me about it all the time, and sometimes I think they misperceive what the settlement is about. They say, it doesn't matter if you get billions of dollars back. That's not going to restore my son, or that's not going to bring back our loved one. You're absolutely right. There are no amount of money will ever bring back the life, and no amount of money is important or equal to an individual human life. That's not what these are trying to do. We've never, and the funds aren't going back specifically to families in terms of compensation for their loss. Where we, as I said before, really think that we can make the best impact and get the greatest ROI is building bigger fences at the top of the cliff, if we want to use that analogy, prevention programs. Because if we never have people getting addicted in the first place, it's so much easier to address.
And the first component of the community is the law enforcement sector. Law enforcement leadership needs to make sure that their law enforcement officers on the front lines have access to Narcan, have training on addiction, opioid use disorder, have the tools and resources to be able to refer somebody to get treatment outside of the law enforcement sphere. So probation and parole officers are regular points of contacts with individuals following incarcerations. This is a great linkage opportunity to get these folks to treatment for their opioid use disorders, treatment for their addiction. And our probation officers need to have the training and the tools to be able to provide this linkage. During overdose spike, social services and schools should be a part of an overdose spike response team. Their roles differ, but both have the goal of protecting children. Health departments need to coordinate within the overdose spike response plan because they have a role in evaluating plans. They can also provide support to local community-based organizations as well. State health departments have resources at the state level, which can be afforded to local and community-led efforts in try to mitigating this threat.
Designing this meeting was an important team effort. We reached out to people across many different professional sectors to bring some of the best thinkers and doers to this meeting to share their work, their successes, and their lessons learned. We hope that bringing these two major themes of innovation and a focus on equity, justice, and fairness help to bring you the kind of content and the kind of inspiration that you need in order to do your job better, in order to help save lives across this country and hopefully around the world.
Okay, thank you for that. Thank you for that, Phil. Okay, Mary, are you up on screen now?
I am, yes, thank you.
Excellent, excellent. Okay, so we heard from law enforcement and the Attorney General from Utah. We heard from emergency medical services, from people in recovery. Those are a lot of different kinds of partners. Anything that it brings up for you with respect to some thoughts about who some of the strategic partnerships might be? And I do want to encourage audience, put your comments and your thoughts into the Q&A and we'll read them off.
Great. Well, one thing I was reflecting on was, how this particular big idea really relates to other big ideas. And where I think too, that really come together very well is what we're talking about, partnerships that work. And what we talked about at our last webinar was reaching people where they're at. And I think in identifying partners, it's really helpful to think back, where are people at? We had some great examples of kind of where people are at during an acute event, how effective that partnership can be with EMS at that moment. But to broaden that also and think in everyday lives, kind of follow the path of an individual during their days, weeks, and months. Who are they interfacing with? Which organizations are serving them? We had a great example in our last webinar, WIC, for example, for women who are dealing with addiction. And that is a fabulous partner that sometimes I had not considered that before that webinar really. But I think it's really effective. And even to think of kind of each of our target populations, for example, pregnant women, or a youth who may be using, taking a pill at a party, each of them where it helps to identify who the effective partners are that we can work with. And really importantly too, how critical it is to have people with lived experience as part of our coalitions or any work we're doing, because they have that information. And also they know who their community will trust. So I just think it's great how all these ideas build upon one another.
Yeah, I agree, Mary. And I think that there's a really nice question raised in the audience. Is there a place that we can learn more about the EMS digital referral to SUNS, to substance use navigators? Well, I would recommend that you take a minute to take a look at the National Overdose Prevention Leadership Summit. There were several people who spoke about an expanded role for substance use navigators, both from the emergency room and connected to other kinds of service providers like the emergency medical services. And Dr. Jean Hearn did a whole session on what was happening with respect to a pilot project in Contra Costa County, which is in California, about the emergency medical services serving in a very upfront, front and center role on helping people in a situation of acute toxicity and getting them into services, connecting them in right away. So that's one place to learn more about it. There also has been a little bit published on that by Gene Hearn and some of his colleagues, and the Bridge program. So CABRIDGE, CABridge.org is another website related to a program that that works very closely with with SUNS and with EMS, and there are some references in there that are that would be helpful. Mary, do you have any other thoughts about that?
Well, just how anytime we're entering into partnerships, it's really amazing as we get to know our partners better, how often our goals align. EMS is a great example. They're just undergoing within the EMS world, this really exciting world of community paramedicine, are doing incredible, are very open to these types of collaborations. Also, they have access to incredible data that, that they're kind of layers of partnerships that are available. But definitely EMS and every community has their EMS agency, usually linked to a state EMS agency, and to find out what's going on in your state and what's going on locally in the jurisdiction. Usually there's an ambulance franchise associated with that, and you can find out who to connect with, and great examples throughout the US.
Yeah, and then there's another comment from one of our attendees. Who are the critical strategic partners for medical associations, such as the American Medical Association, to help enhance treatment for opioid and other substance use disorders? And I really like that question, because what we found in working both in California and other states is that every place is different. Every community is different. In some communities, the local medical society is very, very highly active in seeking out broad partnerships, both to make sure that treatment is improved, but also to make sure that there are some opportunities for prevention that they're deeply engaged in. And so I would recommend starting first with the local medical association. But the American Medical Association had a very potent special task force under the last president, which I think under the current president has been has been reprogrammed a little bit, but there was that interest in the AMA, and they really did sort of hunker down and try to dig very deep into what more they could be doing that that could help set a tone for medical associations across the country. There is a huge role for physicians and other healthcare providers to play in this, and we want to make sure that they are engaged at all levels of their potential. Mary, you have thoughts?
Yeah, I think those are great comments, and also think to the future and well, the current group of medical providers who are being trained. We have wonderful examples, Touro University in California, where they actually have developed a curriculum so every student is learning about MAT, is getting a curriculum on substance use disorder, and this becomes the standard of practice, how we really shift how our medical professionals look at substance use disorder and treatment and recovery.
Yeah, another question that I think is really good, and I'm sorry, I apologize for using an acronym, but EMS stands for Emergency Medical Services. And that's your local, the folks that are usually part of your fire department, but sometimes are independent agencies who go out in ambulances, who are called to respond when somebody is found unconscious or semi-conscious, and to help revive them and get them transported into healthcare settings like emergency rooms. A lot of the folks that are found don't want to go to the emergency room, and because there were so many that had turned away the opportunity to go to an emergency room where they might get a link to treatment services, the EMS authority in Contra Costa County decided to do a trial to see if they could expand the role of the first responders, of the emergency medical technicians, and to see if they could do more. They're very trained people. They have a lot of experience in working with people in crisis. Could they do more to get people that are in immediate overdose crisis, get them into treatment, get them connected to services, do more than just simply give them some Narcan and move on? Mary, you have anything about that you'd like to add?
And along those lines, there's also a program called Give Life a Chance in Northern California, in Solano and Contra Costa counties, where pharmacists and law enforcement, when they leave are in a situation, law enforcement, that they feel may be high risk, they leave behind Narcan, naloxone, and pharmacists will also do this. So really, some of the partners thinking of an expanded role for them also, beyond what you would traditionally see their role as.
Yeah, and one of the points that was brought up in the short film that we saw was the idea that opioid settlement funds could really be doing a lot more than is currently being contemplated. And perhaps do we not have a moral obligation to make sure that the bulk of those funds is spent within harm reduction? And I certainly think you'd see a lot of hands being raised on our side with respect to harm reduction, with respect to the potential of overdose prevention sites, more discussion around what overdose prevention sites are, what they could be, what we know about them, what regulations and laws are in existence that enhance their ability to operate or that prevent their ability to operate. And yes, we are planning some additional work on overdose prevention sites in the future to have some more discussion on that. It's a really cutting edge topic, and we think there's a lot to be shared there. Mary?
Yes, definitely. And I see there's a question about the program just mentioned in California regarding Narcan distribution. I'm not sure if that was Give Life a Chance, which is with law enforcement and pharmacy, or if there was another one folks were referring to.
Yeah. Okay. Into all aspects of it. I like this comment. Should we also consider about how we're incorporating people who use drugs into all aspects of programs, and that we're supporting community distribution of naloxone? It's a very, very good point. And I think that's one of the points that that Courtney Lavelle actually made in her presentation. If you have a chance, go back and listen to her. She was really good and very, very experienced and very grounded. And several other people also had made that point from very different points, very different walks of life. And then, oh good, we're getting some great comments. Thank you so much. We may not get a chance just with this part of our program to get to all of them, but we'll bring them in as we get to the second film, which I'm going to go ahead and actually, these are some, please take a moment to take a look at the questions being asked. There's some very good points here. We'll be trying to address as many of them as we can. Give Life a Chance is located in Contra Costa County. It is, you can actually Google its name, and we'll try to see if we can't come up with that link for you after this next film. We'll post it in the Q&A. So why don't we go ahead and roll the second video.
Welcome to our video series on 5 big ideas in overdose prevention. The following clips are from the National Overdose Prevention Leadership Summit and focus on Big Idea Number 1, Invest in Health Equity.
The opioid epidemic and the COVID-19 pandemic have revealed the awful truth about the war on people. So now we have to ask, when will we stop using the war on drugs as a stick to beat people into submission, to scar them, to lock them out of mainstream society, to use computer tags in the cloud that always identify them as felons or drug users or both? We haven't finished with the old version of the war on drugs. We pay lip service to solutions, but we are still confronted with the attitudes of Edward Williams, well-meaning on one hand, but very much prejudiced on the other. We also have to come to know that young white adults who are perceived as outsiders in the mainstream have been targeted for sanctions, although less than African Americans or Hispanics. President Nixon's efforts, President Reagan's efforts, and even President Clinton's efforts all resulted in policies that fueled mass incarceration, all because the prevailing view seemed to be that not being Black or Hispanic is what made America great. What now? In an ironic twist of fate, we are confronted with the commodification of marijuana, psilocybin, ketamine, MDMA, LSD, and other psychoactive substances. Psilocybin is on the stock market, marijuana is on the stock market, and CBD is in the supermarket. Yet we're still arresting people. The very same things that American Indians, African Americans, and Hispanics have been going to jail for the past 100 years have reached Wall Street for the real money to be made. And big money is not just about selling marijuana to consenting adults in 19 states or medical marijuana in 39 states. It's about how to figure to cater to the International Convention on Narcotics while making money from the masses. And the drug war is about how to continue alienating and suppressing people of color. Our drug policy should be about harm reduction, prevention, treatment, and recovery.
We don't exist up here, and that gets into the politics and the treatment centers and just the most current information to be up here in the northern part of California. All of the tribes pretty much are suffering from the same thing of information and access to services, and the telehealth is a big thing. I think if we banded together and spoke up in legislature of what about us up here, because we don't have the population compared to LA, there's quite a difference of how people are treated up here.
Health professionals have not been taught about the connection between injustice, oppression, and health. I remember less than 10 years ago when I graduated from medical school, we learned about disparities, health disparities. There are different rates of said disease in this population versus this population, but there was never really kind of an exploration about why. And there always seemed to be kind of an assumption that there was some problem with the individual or, genetics or something like that. When the truth is, now that we know, We are all genetically very, very similar, 99.9% similar according to the Genome Project. So it's most of the times probably not going to be, and sometimes there are individual factors, of course, but more focus on the upstream policies, procedures, structural factors are very important.
But I want y'all to really think about, how can I center racial equity in your workflow? When y'all get into the groove of things, when y'all are like firing stuff up, you're assigning roles, you're divvying up, you're making your project management plan, you're doing all this, how are you bringing racial equity into that? And this is a really big question, and it's going to be it'll be hard for us to talk about here because all of our workflows are so different based on organization, the type of work we do, the field we're in, all of that. But it's a question that I think it's important for us to be able to sit with. Because if we're not considering, how is this coming into my workflow? How is every day, how am I operationalizing this? What is my opportunity? What is the moment throughout this work that I'm like, this is where I need to really dig in and understand the impact of this? Is that when you are finalizing the budget? Is that when you're figuring out how to use spin down money? Is that when you're doing hiring? Is that when you're writing this program plan? Is that when you're deciding which one of these requests you're going to approve versus deny because you have limited resources? And understanding that sometimes you're not going to have all those answers. And I really encourage you to get with your community and get with your leadership and get with other equity experts in your field and really like dig into that. And I mean, like, especially if you do anything in emergency departments or hospitals, but really considering like, where does this fit into my flow of work?
Virtually all synthetic opioids that are extremely potent and that have really accelerated the overdose death rate. You're seeing now, it's very clear that this is a racial justice problem. So we can't ignore racial inequalities and other social inequalities in addressing our overdose crisis. And one very quick note about the reasons that fentanyl might be accelerating Black and Native American deaths at faster rates than white deaths, even though white American overdose rate continues to go up sharply, just not quite as sharply. One reason is that Black Americans and Native Americans are subject geographically to heavier interdiction and supply side drug law enforcement, which destabilizes the drug supply and makes it also much harder for people using drugs to know what's in their supplies and to have any control over that. Second of all, mass incarceration has intersected with overdose in a big way, in that the period of time after release from prison or jail is an extremely high-risk time for overdose. People who are released have lowered opioid tolerance if they had been using opioids before because they hadn't had access and had gone through withdrawal in jail or prison. Second of all, they are at extremely high risk for relapse to opioid use. They often by law are ineligible for a lot of social services and housing, have very difficult time accessing healthcare and drug treatment, and are exposed now at very high rates to ultra-potent opioids on the illicit market, including fentanyl. So that's a big reason, big driver for these inequalities.
So we talked a lot with folks about, this isn't a choice people are making. This is part of their brain chemistry. This is part of their environment, everything that they've been exposed to throughout their lives that have come to fruition together. So that was really helpful, I think, for folks to understand it more from a medical standpoint. We talked a lot about medication-assisted treatment and that abstinence, like the sort of old school, you have to be sober to be clean, is outdated and really does not support families who are striving towards recovery. That MAT is sometimes a vital piece of a person's ability to thrive and stay in recovery and take care of their kids. We talked a lot about family separation and how it's especially harmful and traumatic for kids. And again, focused on how can we reunify families faster and also avoid separation whenever possible. So we talked about other options for safety measures to put in place where a parent and a child can continue to be together and bond as much as possible. And even in cases of separation, we talked about how to facilitate more frequent and more meaningful visitation with kids and their parents. And then perhaps most importantly, we tried to help folks reframe the way they talk about substance use. So really just examining our language around substance use and people who use substances. And we talked about person first language. And this comes into play a lot when folks are in and out of court and having people talk at them instead of with them and to them about their use, about their families, about their kids. So I think that that point in particular was particularly helpful for all the audiences that we had in those trainings.
So I want to read a quote from Harvey Milk, the late San Francisco City Council member. He was talking about the LGBTQ community when he said this, but it could just as well be about people in recovery. Because it's not enough to have friends in positions of authority, you have to involve people with lived experience. So he said, a person in office can set a tone, can command respect, not only from the larger community, but from the young people in our own community who need both examples and hope. The anger and the frustrations that some of us feel is because we're misunderstood. And friends can't feel that anger and frustration. They can sense it in us, but they can't feel it. So as much as we want to be an ally and as important it is to be an ally for people in recovery, we won't know and can't feel the anger and frustration that can come from being treated poorly by a doctor or in an emergency room, or know what that shame must feel like, or know the shame or sorrow from losing a loved one to addiction.
There are only two methadone clinics that are public in the border. They are both located in California. People that are coming from other places in the border find it very difficult to get enough money to buy the methadone they would need for at least 1 week, so they don't have to travel that much. So it becomes expensive. And the other issue that I think we have the need of dealing with the psychosocial interventions and housing and other opportunities for people with this type of disorder and fighting stigma. So, and the other issue is that we don't have medications for pain management. No, so we have different types of problems. And I think that nationally we could help each other working in these populations that we share.
And what we can do from a policy perspective to really improve equity and access considerations with respect to substance use treatment. First and foremost, we need to be investing in prevention and universal access to healthcare, not just for substance use, obviously, but also for mental and physical health services. Focusing on schools and our youth is critically important, investing in the future, essentially, as well as investing in and making sure that we have sufficient affordable housing and a really strong safety net in order to serve these vulnerable populations. Another policy recommendation relates to really shifting our approach towards substance use treatment away from incarceration and towards care. Decriminalizing substance use will be incredibly important to reduce the stigma that's long been associated with substance use disorders, for us to better treat it as the chronic and relapsing health condition that it is. Additionally, data collection will be pivotal to better understand local needs. And then, perhaps one of our most under-leveraged evidence-based interventions, medications for addiction treatment, or MAT. This is something that we need to expand across the board. We really have set the goal of having MAT available in every site across our specialty substance use system in the future. Although there's a fair amount of infrastructure building related to workforce and financing that we need in order to get there to that goal.
And so the sounds of war rage, the sounds of discontent rage, and I believe that part of that noise comes from a disingenuous war on drugs that has lasted over 100 years and that needs to come to an end. And so we can answer the question of what now, starting with an honest appraisal of what we did, and so that we can figure out what we need to do.
So what we'd like for people to do, again, please help us to generate some discussion around what's one way in your community that you currently invest in health equity. Want to make sure that we get your best ideas as well as the things that we heard and that we'd like to share with you. So I think that I was really moved by the comment that that Dr. LaBelle made about setting a tone and making sure that we have some ways to make it clear that we are here to serve, we are here to listen, we are here to respond to what our community tells us they need, and sometimes that's not totally in alignment with what we're set up by our funding streams or by the structures in which we work, and so that's why we brought up this question about investing in health equity. Wanted to have people think for a moment about why it's important in order to make sure that we're really saving all of the lives that can possibly be saved, and that make sure that we're really connecting to all of the people that need to be a part of this voice in lifting up what is needed at a community level, and to really examine why we don't always do that, and take a moment to think about what are the steps we have to take in order to turn that around. Mary?
Yes, I think this is so important. One thing that kept coming to mind for me was the image of the iceberg. You know, there several things were discussed. The excellent discussion about the war on drugs, the different outcomes in racial and ethnic groups. Those are kind of the tip of the iceberg. But if you go down deeper, I mean, as was said, expressed so well by Dr. Hansen, you know, that why are there more overdoses potentially in among African Americans and other racial and ethnic minorities where they're higher incarceration rates? We know that as one element. One element of overdoses is the fact that people, it's the point of highest risk of overdose when you're released. These are all connected, and underneath at the bottom, the biggest part of that iceberg generating that peak, the tip of the iceberg, are these racist beliefs and attitudes. So how do we really look at all levels? And I thought the comment by the individual Charles, I think it was Charles Hastings from the Edie Bridge, that how do we incorporate this perspective into workflows, into what we're doing every day, is so important and a very important challenge to take on.
Yeah, and Charles Hawkins, his part in you only heard just a little bitty smidgen of what he shared with the audience, but that's really what he spends a lot of his time doing. He and the physician who spoke just right after him, the two of them spend a huge amount of their time thinking about how do you center health equity. It does sound like a lofty idea, but it really isn't, because if we aren't thinking through and really trying to systematize how we ask ourselves, who's at this table? Who isn't at this table? Why aren't they at this table? What do we have to do? Who do we have to reach out to? Where do we have to go to make sure that we are including the whole community, not just the part of the community that comes to our place, but the whole community of whom we know there are the issue of the chronic disease of substance use disorder exists in every segment of our society. What I think that we heard in the meeting that we held was that there are segments of society over and over again that are ignored, either by systems, by law, by policy, that excludes them from access to understanding substance use disorder as a disease, and instead makes it a crime, whether that's a system that does that, or whether we just are blind to the very realities that are in front of us. What needs to happen inside of ourselves, inside of our systems, inside of the places that we work, to think very actively every day, every time we see somebody, every time we don't see somebody. What did we do? What didn't we do in order to make the issue of equity something that helps us to understand how are we connecting? How are we not connecting? And what do we need to do to connect? So I'd recommend go back and take a look at the session on centering equity. It was really, really packed full of very good examples. I'd like to just sort of comment on some of the questions being raised by the audience, some very good points. How do you not provide, how do you provide information to the community and not use scare tactics? Well, my thought about that is that, goes back to the idea, substance use disorder is a chronic disease. You have to start with that. It's a disease. And we need to find places to connect with people over the topic of that disease and make it more of our normal language. If we can talk about diabetes, that's a good start. But, why aren't we talking about substance use disorder in the same way? So that's one important connection we need to make in our own minds to turn that around. Mary, you have some thoughts for how to do that even better?
Yeah, and actually Sol Gonzalez asked that same question, if we know it's a chronic disease, why aren't we treating it as such? And I think it goes back to the issue of stigma, racism, all of the not wanting to address this issue. And it has to be, and I think, again, we have to, as Carmen was saying, the issues of equity are so, or inequities, probably better, are so diffuse. We have to look in each of the areas of, when we going back again to our partners and everything, where can we influence this? Where can we change as a medical profession how we look at substance use disorder? We have this artificial, division between behavioral health and physical health. But why aren't we? Why aren't we changing policies related to that? The chain of changes and events that occur once we address the stigma, the racism behind many of these policies and perceptions is just ongoing and will dramatically shift the course of events in terms of addressing substance use disorder in an equitable manner.
Yeah, and there's a couple of nice policy points that members of the audience have raised. One person pointing out that there are some excellent strategies, some excellent tools that we have in our toolbox for trying to address overdose prevention, fentanyl test strips, naloxone. What do we have to do at a policy level to make sure that these services become ubiquitous and become really truly accessible to people from all communities? So it can't just be the people going into treatment programs that they can afford. It has to be people on the street who are suffering. It needs to be people who are trying to access service. It needs to be people who maybe have had or observed an overdose in their family. All of those folks need to have access to things that are truly life-saving tools. Now, the policy is out there already in many communities. It's beginning to be implemented at a federal level. It's our job, even if it isn't your job, it's our job to advocate for the implementation, the distribution, the use of the education around the tools that will help to save lives. If you're listening to this webinar, it's because you care about this issue, you care about the lives being lost. We need to equip ourselves with the best knowledge that we have, that we can access about what does the law really say, and why are we not getting naloxone where it's needed, or fentanyl test strips where it's needed, or medically assisted treatment where it's needed, and how do we push that envelope always, every day in our settings to make sure that substance use disorder, a chronic disease, gets treated and gets prevented. Mary, thoughts?
I think a big part of that too is trust. A huge casualty of the incredibly inequitable society that we have is trust. And so having individuals from communities that are disproportionately impacted, who are engaged in the design, the direction of policy and implementation is just critical if we are going to have equitable access to services and support.
Yeah. So, I'm just sort of scrolling through some of the comments people are making, and I think that a lot of you are trying to manage in a situation where you're seeing a lot of stigma and you're wondering how you can be more effective at addressing it. And I just have to say, this is all about a process of building a conversation on a daily, on a weekly, on a monthly basis within your communities as often as you can about substance use disorder being a chronic disease that impacts lots of people from all walks of life, that touches people who normally aren't brought into our systems and should be brought into the systems that we serve. And it's a process of making this the daily language that we use to understand substance use disorder and that we use to help others understand substance use disorder. It's part of our jobs to normalize the conversation and to make sure that people have the facts that they need. And the facts are there. We're just not doing as good a job of distributing them as we might. We're not repeating as many times as need to be repeated the need to make sure that everyone appreciates the humanity of every single person who has this disease in the same way that we appreciate the humanity of somebody with diabetes. There is no difference, and we need to respond in an evidence-based way to make sure that they can live their life in a way that allows them to be as fulfilled as they can. And that's what we're hoping comes from these sessions. We're hoping that, I hate to see that our time has just been slipping away from us. These are very important comments and I wish I could read them all. I hope that you all have had a chance to take a look at them. We are hoping that you can walk away from these two webinars with an overview of what the big questions are. We also just want to reiterate that we'll be going into much deeper discussions on these issues in the upcoming series. So, tune in again, come back to the website, the NOPN.org, come back to that website and see what we have scheduled. Our next session on March 9th at 11 a.m. to 12 p.m. Pacific time is going to be a longer discussion on how to invest in health equity. And again, you are welcome to come back to that website, NOPN.org, to find a link to the national meeting and make sure that any sessions there that you want to view, they're all free. Please, take advantage of it. We were hoping to give you a little bit of a taste of the sessions through these short films. And we think there's just a lot more to share there. So just on for a second to the last couple of slides here, please. Okay, our next workshop will be Trauma-Informed Practice, Part 1 on February 23rd, 11 to 12, and please sign up if you can. This is a very important and increasingly more important series of webinars that we're giving. We just, we've had such good response to it, and these are all, please, free, open, invite people that you think might be impacted, and go back and review the webinars after they've been recorded and posted. There, you're welcome to do that. And then the final slide. And please join us as part of this community. NOPN.org. Help us by giving us the best, your best feedback on how this session went. You're going to receive a questionnaire in just a moment to just give us some feedback. Tell us what you need to hear about, what you want to hear about, what your community is not, where they're not moving or where they are moving, where we could lift you up as an example. Would love to do that. So from all of us at the National Overdose Prevention Network, we want to thank you for joining us and hope we see you again. Thank you so much.
Thank you.